Looking at it from my perspective, patient safety is the most important topic we have in medicine today. As an anesthesiologist, I work in a very technical environment where many mistakes can happen. In this field, such mistakes or oversights can have lasting consequences for the patient. Despite the fact that anesthesia-related mortality has significantly decreased over the past 20 years and continues to decline, the figures are unfortunately not decreasing when you look at the entire perioperative process. And it is here in the entire perioperative area that we as anesthesiologists have to take responsibility. My personal incentive concerning the subject of patient safety started at the very beginning of my career. When I first came to the department, our regular morbidity and mortality meetings always felt as though we were looking for someone to blame and ended up with accusations such as, "Couldn't you have done that better?" And so it became perfectly clear to me that this was not the right way to continue forward. The fact is that we need to learn from our mistakes so as to avoid them in the future and do things better. That's what you have to take with you. In my opinion, the error culture in hospitals still needs to be improved. Far too often, only the error is looked into so as to find the one who did it. Hierarchical thinking still exists in medicine today, which means there's often neither the time nor the will to learn from our mistakes in order to redesign the whole system differently for future improvements. The question regarding the main factor is not an easy question to answer because I'm sure that it is a combination of different factors that are involved when incidents occur. One factor to consider is the patient themselves. As the patient gets older, their pre-existing conditions also become more complex. Here is where we often find ourselves outside the standard norms. Another factor is the resources needed in hospitals where they are already facing pressures to be as cost-efficient as possible. Some other contributing factors are staff shortages in all areas of the hospital, more complex and integrated technologies, which mean that errors are more challenging to find than before, and the exponential growth of knowledge. Nowadays, we live in a knowledge-based society and have yet to find a concept as to how to deal with this great amount of knowledge. Today, we face the challenge of making the right knowledge available at the right place at the right time. When problems arise, though, I often hear the comment, "I didn't know that." We work in an environment where we have countless guidelines to adhere to. For example, implementation recommendations from societies as well as SOPs. It's no longer possible to keep in mind the most up-to-date version at all times, but we need to know where to find this knowledge somehow.
Aber man muss wissen, wo man an dieses Wissen rankommt. The Safety 2
concept takes a fundamental turn from its predecessor and has a completely different approach than previous concepts. With the previous Safety 1 concept, the focus was on finding and fixing the cause of the error. In this reactive system, people tend to point fingers at the human being as the cause of the error. In this concept, safety was defined as having as few undesirable events occur as possible. The Safety 2 concept has a totally different and integrated approach. Here, safety is defined in such a way that we learn from well-managed incidents instead of focusing on errors. The whole system is therefore proactive and continues to factor in incalculable events, which can never be planned. And this is exactly what we see in our daily clinical reality. Simulation trainings are very helpful here because we can train both the technical skills and non-technical skills during these simulations, such as essential communication in the team. Moreover, our simulation center has a very realistic room in which we can depict the clinical reality one-to-one. At the core of all our trainings, there is always a video-based debriefing at the end, where we can show participants exactly how their actions affected others as well as how they communicated. I believe the most important step we took was to have these trainings firmly defined and integrated into our departmental goals. Our goal is to have 85% of our employees on the simulator once a year. In reality, this is also a challenging situation for us. However, with a little bit of involvement along with a boss who supports the whole team, then something like this can also be implemented in modern times when resources are always in short supply. What makes me particularly proud here in Hannover is that we have succeeded in integrating a 5-hour simulation course for students in their 4th year of study into the compulsory curriculum. Every student who comes to us will also receive a 5-hour course on patient safety.
For
the future, we would like to develop course formats that are based on the theory of safety too. However, we still have to think about a few things in order to do this, because this is a completely different approach to error management. If we were to wish for something like this, then I would also wish that we could have more scientific tools at hand with which we could prove the things we are convinced of scientifically.